I work for the National Institute of Mental Health, and that's a federal government position, so I have to disclose that this does not, none of the comments that I make represent the official position of the federal government of the United States, but the work that we do at the National Institutes of Health is wholly supported by the federal government research programs. So bipolar disorder, well known to everybody here, is relatively rare, although much less rare than we previously believed as we've moved to general population surveys across the world. But the reason bipolar disorder has such impact is because it starts early, and as I'll tell you today, starts earlier than many of us had previously believed. It tends to be a chronic disorder that waxes and wanes throughout adulthood, striking people at the key points that they need to accomplish life's developmental milestones, and as such interferes with people's accomplishment of not only their ability to function in life, but also their education, social development, and life development as parents, and in their occupations, very similar to the demographic manifestations of schizophrenia. So it's quite parallel in terms of its onset, although its underpinnings may be somewhat different. So the goals of my talk today are threefold. First, I'd like to talk about the lessons that we've learned from doing population-based studies, and this is descriptive epidemiology that's moving now across the international scene. As we've heard in the earlier lecture today, this has really provided very important clues about the causes and risk factors for conditions when we see differences in manifestations in different parts of the world. Secondly, to talk about how we've brought the findings from population studies to clinical samples, where we've started what we call next generation family studies, where we explore the patterns of transmission in families by trying to dig beneath the categorical phenotypes that have characterized genetic studies that have made major contributions to our understanding of the genetic and environmental risk factors for these conditions over the past 50 years. And then finally, talk about some of the core features of bipolar disorder that we're studying intensively over time using mobile technologies to try to understand how the components of bipolar disorder, particularly activity, sleep, mood regulation, underlie this condition, and how these disturbances may really be the core features of bipolar illness and somewhat change our conceptualization of this condition as a unitary phenomenon that is a manifestation of a single underlying dimension, from mania on one end to depression on the other. So let me start with what we've learned about the epidemiology of bipolar disorder. The World Mental Health Surveys are the largest aggregation of studies across the world where we have investigated the patterns of major common mental disorders across all continents across the US, certainly not all countries, although we'd like to accomplish that. Because I think the more that we can study these patterns of disorders in some other countries, as those we've talked about earlier today, I think it might give us clues about the risk factors and causes. So these studies, we investigated about 23,000 adults across the world, and examined psychopathology for mood, anxiety, substance use disorders, eating disorders, and so forth, using the same diagnostic methods and the same structured diagnostic interviews to collect those data. Now, one of the major limitations of these studies is that we did not ask about psychoses. At the time we developed these studies, we had not been aware of the tools that were available to characterize psychosis in community studies that were referred to in the earlier speaker's talk. And if we were to expand these studies now, I think it would be very important to characterize patterns of psychotic symptoms, subclinical psychosis, as well as social communication and other conditions that we did not collect because we believed them to be too rare when we started these studies. So what we found, I think the major finding was that, of course, bipolar disorder affects about 1% of the population across the world. There was some regional variation with lower rates in India and Asia. And the highest rates of bipolar disorder were in the United States and in Australia and New Zealand. But generally the rates in Europe, the United States, Canada, and so forth hover around 0.8 to 1% of the general population. One of the lessons we learned, however, was that when we asked people retrospectively to date the onset of their first episodes of either depression or mania, we found that almost half of adults who met full criteria for bipolar disorder had reported manifestations before the age of 20. So about 50% of those who meet criteria for bipolar disorder report onset in adolescence. And now, when we put that together with prospective studies that have been followed followed adolescents and children, we find that about half of the cases of people with bipolar disorder in the general population will have their first episodes, usually post-adolescence and through adolescence and early adulthood. So if we want to target a period in which we see the emergence of either manic episodes or depression, we really need to move lower in the spectrum, and that is move beneath the arbitrary threshold between what is adult and child psychiatry. The other most important lesson I think we've learned is this term called comorbidity. And I believe we were one of the first groups to use that term back when I was working with Myrna Weissman at Yale, when we started to apply diagnostic interviews in the general population. We realized people meet criteria for multiple disorders simultaneously. So when we're counting rates of disorders, we're counting people multiple times. Because when we evaluate someone with bipolar disorder, and this is in the general population, 70% of people who have bipolar disorder suffer from 3 or more other mental disorders across their lifetime. This is not necessarily simultaneously, but those of us who work in this field know that substance abuse is one of the most common consequences of the development of bipolar disorder. And it's quite different than the patterns of cannabis use and psychosis that we heard in the earlier lecture. We can clearly show that alcoholism is a consequence of the development of mania. So people tend to drink during manic episodes, and those who may have independent risk for the development of alcohol dependence develop alcohol dependence over time, and they are never recognized as suffering from mania or underlying symptoms of mania when we see them in clinical settings. People with bipolar disorder also tend to suffer from anxiety disorders. The majority of people with bipolar disorder will suffer from a history of panic attacks, not necessarily disorder. Social anxiety is particularly associated with bipolar disorder, and generalized anxiety, and so forth. Phobic states tend to be more strongly associated with the bipolar form of mood disorders than with major depression. Major depression tends to be more strongly associated with generalized anxiety and panics. So we're starting to see some separation here in terms of patterns of comorbidity. Now, this does not speak to the work that we've been doing recently in a very large cohort study in the United States of 10,000 children from pediatric settings, where we show that the majority of children who suffer from mental disorders also suffer from 2 or more physical disorders. And those with attention deficit disorder, which were formerly characterized by having disorder before the age of 7, we find that they have been identified with 2 or more learning disabilities, dyslexia, other symptoms earlier in life. So even children with these conditions tend to suffer from multiple conditions. And hence, we really, when we're characterizing the rates in general populations, we should be talking about the rates in people and not the rates of disorders, because it really is misleading to say that these are the rates of bipolar disorder when we're not considering the patterns of comorbidity. Now, interestingly, comorbidity is the major bias that we see that leads people to clinical settings. So that when we examine people in clinical settings, we see that they are truly the tip of the iceberg of what is really there in the population. And during the last decade, at least in the United States, we don't have data across the world, but what we found is that there is a decreasing tendency to treat people with bipolar disorder in mental health specialty settings. So now we see that the majority of people with bipolar disorder who we identify in the population who are treated, and that's only about half, they're treated for depressive episodes. And primary care physicians and pediatricians do not recognize either anxiety disorders, and most importantly, they don't recognize manic symptoms. So they don't characterize the mania, they're treated for depression, and hence in many cases we see that they're unleashing the symptoms of mania in people because they're not recognized. They're seen as anxiety symptoms that are secondary to the use of SSRIs and so forth, and they're not recognizing the risk that these people are developing manic episodes. And of course we know manic episodes are oftentimes related to suicide attempts and so forth. So this tendency to treat people in the general care sector is really, it's really a problem because people are not being recognized for the underlying bipolarity of their conditions. So then we've looked in a very large survey in the United States to start to study adolescents to understand the manifestations of these conditions in children ages 13 to 18. So these are only adolescents. We have not looked at children younger in a nationally representative sample of the United States. But I wanted to show you some of the findings from this study that has led us to reconceptualize how we study mania in our clinical and genetic and treatment studies. So I want to go beyond the slide talking about the lack of treatment of these children to show the results of a latent class analysis of the patterns of symptoms of mania in adults and children. So the top graph shows the probability of symptoms of mania among adults, and the lower shows the probability of symptoms among adolescents. And these are people who enter the mania section of our diagnostic interview. Now, there are two major findings from both adults and children that have led us to think differently about bipolar disorder. First is the patterns of symptoms of mania are remarkably similar in adolescents and adults. So we really are starting to see the same patterns and clusters of symptoms in adolescents. Starting around the age of 14, 15, 16, we start to see manic episodes. And they have the same symptom profiles of those with adults, with the exception that they have less consequences, less impairment, and shorter duration of symptoms. The second major finding was that increased activity is the most common feature of mania in both adults and children. When you look at mood changes, actually that is not even present in about half the cases of people who meet criteria for mania. So we started to focus more on the changes in activity in people with mania, because this turns out to be one of the most objective and core features that, as we've now tested these symptoms in the population, we're finding that we have many more adolescents and adults endorsing changes in activity who do not endorse changes in mood, elated mood, feeling high, In fact, only about half of the people do report those symptoms, even though they have changes in their in decreased sleep, flight of ideas, et cetera, et cetera. So the second finding from our adolescent study, and this is one that really changed the way we think about bipolar illness, is shown in this slide. And what we show here are the rates of major depression in adolescents with these other conditions. So what you'll see is about 50% of adolescents from the general population who had generalized anxiety disorder had a major depressive episode. Similar patterns we see for PTSD. Youth with PTSD, about 50% of them had major depression. Mania was lower and in the middle. So among those with mania, less than half had had an episode of major depression, about the same number as those with eating disorders and social phobia. So what we interpreted these findings as possibly implying is that depression may be a manifestation or secondary to many different disturbances of adolescent behavior and emotions. Not shown here, children with psychosis also tend to manifest depression, and oftentimes they manifest depression earlier than they do the psychotic symptoms. So we're beginning to see depression as a non-specific indicator of disturbances in multiple systems, be they behavior, emotion, or eating, or cognition. So this led us to question, well, what is the relationship between mania and depression? And indeed, is bipolar disorder truly a unidimensional condition that ranges from high to low mood? So, in summary, from our studies of epidemiology in population samples both across the world and in the US, particularly as we move down in the lifespan, we see that bipolar disorder is manifest as a spectrum. People here in Italy are some of the primary initiators of the concept of the spectrum of bipolar disorder. Unfortunately, Dr. Benazzi is no longer with us, had discussed this extensively and how we characterize the spectrum of mania and hypomania in our patients and population. Secondly, comorbidity of mental and physical disorder is pervasive. So when we study bipolar disorder, when we do treatment trials, if we exclude comorbidity, we're missing the bulk of people who suffer from these conditions. Third, there's a growing gap between who we see in the clinics and who we see in the population. And this is why when I moved to the National Institute of Mental Health, I thought it was extremely important to collect families from the general population rather than from treatment settings, clinical settings where the bulk of our information about the heritability of mental disorders, our family studies, our adoption studies, are basically been established on the basis of clinical samples. Fourth, that manifestations in adolescents start to approximate those we see in adults. Similar to the developmental pathways to schizophrenia, we start to see the manifestations even earlier. For schizophrenia, we see the changes in neurodevelopmental factors earlier, and we don't tend to see that in bipolar disorder. We tend to see no differences before adolescence, and then we start to see the changes emerge post-pubertal in children with bipolar disorder, I think, which is one major difference is in the course. And finally, that activity, sleep, and circadian disturbances may supersede mood changes as a core feature of bipolar disorder. Okay, now let me move on to how we've tested these concepts in a large family study of mood disorders and behavioral health in a general population sample of the region of the National Institutes of Health in Washington, D.C. in the U.S. So what we do in our studies is we start with general population samples. We then move to extended families, where we can study the phenomenology more carefully, intensively, and follow people over time. And we've now included biomarkers as well as clinical and demographic factors as part of the risk profile. Again, as we saw in the earlier discussion, we need to look at comorbidity with substance abuse to see how that either triggers the onset of these conditions or affects course and treatment. So what we did in our family study, and this work was published in Molecular Psychiatry last year, we studied 500 adult probands who were selected from the general community but enriched for bipolar 1 and 2 disorder through the NIMH clinical screening protocols. So we have a total of 500 adult probands. We've interviewed first-degree relatives. We're moving into second-degree relatives as well, and most importantly, studying their offspring so that we can follow them over time and put this together with numerous high-risk studies of bipolar disorder. They're ongoing across the world. We established a diagnostic interview that does not adhere to a particular diagnostic system. The SCID that is widely used in the United States is strictly adheres to DSM-4 and now DSM-5 criteria. So if you do not meet the phenomenologic criteria and duration of 2 weeks or more, have it all day, every day, with impairment, we don't even inquire about the phenomenology. So what we did was, following my mentor, Jules Angst from Switzerland, we asked about phenomenology first, and then we characterize duration and characterize impairment. And I think most importantly, which I think most important innovation by Professor Jules Angst, was to include recurrence as a core criterion for mood disorders. We now can characterize major depression a single episode, and although we have qualifiers to say single versus multiple episodes, recurrence turns out to be extremely important because we have recurrent brief episodes of mania in adolescence that then may develop into more longer episodes, and yet many of these completely dissipate as people develop into their 20s and 30s and they go away. So the question is, what makes the difference between those who progress and those in whom these kind of brief bursts of impairing mania dissipate over time? Okay, the other characteristics is we looked at biomarkers in probands and their relatives. We bring them into the clinical center of the NIH. And as I mentioned in the last few minutes, I'll talk about using mobile technologies to characterize people over 2-week epochs so that we can characterize in vivo changes in sleep, activity, mood states, and so forth. And then we are repeating these over time by seasons. So the main question was, what is the relationship between mania and depression in families? Because if indeed they're distinct, we should see that they aggregate in families, which is indeed what we found. We found that mania was highly familial, with an 8-fold increase among the relatives of people with mania, and a familial, not necessarily genetic heritability of 0.83. Now, what's interesting about this is very remarkably similar to the study of the Maudsley Twin Registry, where they investigated mania, the heritability of mania and depression. Their heritability, additive heritability of mania, was 0.86. For hypomania, we did not find a significant familial aggregation. Partly, I think, attributable to the hypomania is defined by a lack of impairment. So it's very difficult to characterize hypomania reliably, particularly in non-clinical samples. And then, again, repeating what have been found in multiple studies across the world, we found about a 2-fold increase in major depression in families of probands with major depression and a moderate level of heritability. Now, the key question, if we want to determine whether mania and depression are in a single underlying dimension, is that we would expect to see that relatives of probands with mania should have an increase in rates of depression, and the converse, people with depression should have an increase in among their relatives in mania. And here are the findings. This was absolutely shocking to us. We found no overlap. The odds ratios were even negative partly attributable to power, low power for detecting mania, but we did not find a significant cross-aggregation of mania and depression in families. Now, not shown here. As Dr. Murray said earlier, as an epidemiologist, we never believe anything unless we see it in about 10 studies. So we have a parallel family study that's being conducted in Lausanne, Switzerland. A former postdoctoral fellow of mine, Martin Preisig, who's done a much better study than I ever could have done, did a very large clinical family study of the spectrum of schizophrenia, schizoaffective disorder, mania, and major depression in Lausanne, Switzerland. So what we showed there was identical findings. Mania was specific, depression was specific, no cross-aggregation. But then in that study, we could look at the main effect of psychosis. We found the same main effect for psychosis without cross-aggregation with bipolar, with mania, or with depression. And this suggests that we have 3 underlying domains which really map onto how we treat people. Somebody comes in with psychosis, we treat the psychosis. Somebody with mania, we treat the mania and the depression and so forth. What this suggests is all these fine these characterizations, schizoaffective manic type, schizoaffective depressed type, psychotic depression and so forth, may not be as meaningful as whether people have psychosis, and maybe whether it's induced or not. But I think these main effects really kind of simplify the picture of trying to put people in these boxes that have emerged. And I have to emphasize that it's based on clinical samples. And how do we characterize people? Okay, so what we found that mania and depression appear to be independent in terms of underlying familial liabilities. We replicated these findings in an independent sample, independent ethnic group, certainly more homogeneous. Not shown here, the atypical subtype of depression tends to be highly familial and probably more associated with bipolarity. So what this suggests to us, there may be a dimension of fatigue and high energy rather than a dimension of depression and mania. So we're studying those possibilities at this point and following the offspring. Okay, now in the last few moments, I'd like to talk about how we've studied the core features of bipolar, of mania, depression. And of course, we also have large numbers of people from the population with sleep disorders, with anxiety disorders. So we've been trying to dissect all of these major conditions to look at their overlap and manifestations in families and over time. So these were the major domains of risk that when we started the study in 2004 had been postulated to be so-called endophenotypes or biomarkers for bipolar disorder. We had brain morphology, we had neurocognitive functioning, reactivity. There is postulated increased reactivity to environmental and biologic triggers in bipolar disorder, temperamental differences, and finally rhythms. And we haven't analyzed all these data yet. I wanted to add the olfactory dimension because we are interested in sensory thresholds. So we actually systematically test sensory thresholds because several experts in bipolar disorder reported to us that people during manic episodes have enhanced sensory phenomena in terms of increased color, increased smell, increased detection of these kinds of senses. So we wanted to see, could this be one of the underlying domains that's interesting, that's characterized by people with mania? But the main domain where we have our findings have emerged have been for rhythms. It really looks like activity, changes in activity seem to be a very important core feature as we discussed earlier and identified in our adolescent sample. Now, as we all know, there's nothing new. This is not the genetics Mendel, who was one of my heroes. This is Emil Mendel, a German neurologist and psychiatrist, when we used to be trained in neurology and psychiatry together. And Emil Mendel said that mania is a functional disturbance of brain with increased excitability. manifest by increased speed of all processes, and that mood change was not a core feature. So we see this increased excitability of thoughts, of activity. Things go much faster in time, and we've all heard people with mania describe this. So by using mobile technologies, we hoped that we could capture this to some extent. So what we did is we used activity monitors. Now these are now everybody, all of my friends are using activity monitors to count the number of steps per day. These activity monitors were used in Britain 30 years ago. People started to look at physical activity as a manifestation of mania. But what they didn't have at the time was the ability to follow some of the ability for us to look at circadian patterns. The genetic architecture of the circadian systems had not been characterized to the extent that we've now been able to do with the tools of molecular biology and so forth. But what we did that I think was unique in our study was we coupled it with cell phone technology where we measured people's mood states, activity, energy, life events, and so forth 4 times a day for 2 weeks. So we were able to look at changes in activity as a function of sleep, mood changes, energy, and so forth. So I'll just tell you in the last few moments what our major findings are. We're about to report these now. So we think they're very interesting and hope that we can try to replicate these in other settings and other samples. So the first finding here that we show is if you focus on the lower graph, this shows the amount of activity along the lower axis. I think that's my pointer. It shows the amount of activity across 24 hours as a function of the amount of sleep. So yellow is high sleep, blue is low sleep. And what we find in controls is if you have increased sleep, you have decreased activity throughout the day. But what we found for people with bipolar disorder is they start out having less activity, but with increased sleep, they have a shift at midday such that they have an increased activity later in the day. So this suggested there was a circadian shift that increased sleep leads to an increase in activity in people with bipolar that it does not in the general population and controls. Secondly, when looking at the relationship between activity and mood, SAD mood rated on an analog scale 4 times per day for 2 weeks, we found that increased SAD mood, which is shown in yellow, to decreased SAD mood shown in blue, we find that decreased activity is related to increased SAD mood and converse. So what you find throughout the day is if people have less activity, they are more likely to have SAD mood in the converse. Finally, when we put this all together, what we found was a unidirectional pattern of association across mood states, sleep, and activity, such that energy was associated with increased activity in the next period, and that increased activity was associated with decreased SAD mood. We did not find the opposite directionality of these findings. So if you have decreased SAD mood or increased SAD mood, there is no change in your activity. And finally, activity does not increase energy. We had hoped that that would be the finding. But what this suggests is the core driver of this is decreased energy. And if we don't treat the decreased energy, we may not have any impact at all if we treat people's mood states or we do physical activity interventions. And indeed, my recent review of activity interventions for depression is that they have not been successful in changing depressed mood. And finally, people with bipolar disorder have much tighter coupling across these systems. So if somebody with bipolar disorder has decreased energy, they have a much greater decrease in activity and a much greater decrease in mood. So much tighter associations across these homeostatic regulatory systems. So there's a greater independence of these systems that probably harpens back to the circadian systems and homeostatic systems of the brain. So, in summary, we see that circadian patterns and increased variability of activity is a key feature of mania that warrants further investigation. Joint applications of these kind of activity monitors with in vivo measurement of mood states, sleep, diet, and so forth is a powerful method to look at these regulation of these homeostatic systems in people with bipolar disorder, but also other disorders as well. And this unidirectional association suggests that we should be focusing on the biologic determinants of energy, which is a very interesting biologic problem that we have now been studying in translational models of both mice and primates. My final comment is that we're starting to intervene in these pathways early in life by collaborating with a group in Sydney, Australia, where we're bringing in adolescents who have these manifestations of increased energy, increased activity, and so forth by intervening, by trying to do exercise, rhythm interventions to see if we can offset the subsequent development of full-blown bipolar disorder. So, I want to thank you for your attention and thank all of the colleagues that have been involved in this work. It demands that we have multidisciplinary collaborators both within the National Institutes of Health and across the world and within my own team. Thank you very much.